Well, good afternoon, everybody. This is Chuck Hibbard. I'm originating from Reagan International Airport and excited to have this opportunity to the inaugural Next Generation Extension Learning for Leaders webinar in ECOP's pursuit of representing the entire Cooperative Extension section with our focus on key partnerships with APLU, USDA, NIFA, other federal agencies, non-government organizations, and the public. We've assembled as many of the 76 extension directors and administrators as possible today to help answer the question, what are leadership opportunities for extension directors and administrators to make a difference with the opioid epidemic? In addition to our extension directors and administrators today, we have representatives from the 1994 land grants, the Extension Foundation, National 4-H Council, NIFA, and others. Thank you all for being here. A special note of thanks to Angie Rushman from Nebraska Extension for assisting the presenters and handling the technology for the day, and to the Extension Foundation for securing Zoom license for ECOP to conduct these meetings. As we progress through this webinar, please use the chat to log questions or comments, and we encourage you to tweet to hashtag CoopEXT to share your thoughts or reactions more broadly. I want to start by introducing Chris Borboom, chair of our ECOP program committee, to lead off this webinar. Chris?
Okay, thanks so much, Chuck. Today we're going to
yeah, it's like you can't miss it.
if people could mute their microphones, that would be most appreciated. Today we're going to rely on 3 individuals to help us through this discussion. Ann Lindsay from University of Nevada, Reno, a specialist there. Alicia Shipley, the NIFA National Program Leader for Family and Community Health, and Mark Skidmore, who's the director of the North Central Regional Center for Rural Development. And Mark is going to move us on to the next slide.
Okay, thanks, Chris. Thanks, Chuck. You all can hear me well?
Okay, thanks, Mark. On this slide, I just want to make a couple points here, provide a little bit of background in regard to this webinar. So I'm the chair of the ECOP program committee, and we've been discussing the possibility or the role for cooperative extension as a national system with different issues. And the opioid issue crisis has come up in the discussion quite a bit. We surveyed extension directors and administrators at the NIFA meeting in October. So we know this is an important issue, but it differs between regions and between institutions. And so the program committee was trying to see how to best address the issue. And so we thought our next step would be this webinar to provide some baseline information so that we could have a discussion about leadership roles and opportunities for ECOP and extension directors and administrators. And so with Ann Lindsay and Mark Skidmore and Alicia Shipley, they are going to provide some of the expertise for us to talk about opioid epidemic, the crisis. And then after we go through some of this background information, as you can see here on this slide, we're going to come back and close up and wrap up so that we have time for discussion to see what and how and where we can go as an extension national system in addressing this. So I'll turn it over to you, Mark. Please take it away.
Okay, thanks, Chris. Nice to be with everyone today to talk about this important issue. What is the problem? Since in 2016, more than 2 million Americans have had an addiction to prescription or illicit drugs. 300,000 people have died since 2000. Drug overdoses are now also the cause of leading injury death in the US. So in addition to drug overdose deaths, there are injury-related deaths. In 2015, there were more than 52,000 drug overdose deaths, nearly 2/3 of which involved opioids. And the trend is continuing upward. So we have, I think, an ongoing challenge in the coming years to address this crisis. About half of all U.S. opioid overdose deaths involve prescription opioids. Furthermore, many of the heroin overdose deaths began with addiction to prescription opioids. So there's this link between the two. And as we try to tail off our access to prescription drugs and try to tail that off, there's a trend toward looking to other sources of opioids, and that can be on the street with heroin or other types of synthetic sources of opioids. So the most common overdose opioids are methadone, oxycodone, and hydrocodone. I guess it's fair to say that that the opioid challenge really began in 1995 when the FDA approved OxyContin, a form of pain reliever that was marketed heavily and thought to be non-addictive, when in fact it is very addictive. And so you can see the trend of prescription opioid related deaths in blue. And as that's tailed off, you can see that heroin and synthetic opioid fatalities are on the rise. So all three of these are interconnected and related. In addition, the United States is a real outlier in terms of these kinds of problems. While these kinds of pain relievers are available in other places, you can see the United States is far and away has the most fatalities related to these kinds of drug overdoses. So clearly, there are a lot of reasons for that. It may be because of oversight and marketing differences regarding how the prescriptions are made over time. So it just provides some context of the magnitude of the problem and how the United States is really adversely impacted more so than any other country or industrialized country. I think this graph or this series of charts here kind of helps you see the pathway to the opioid fatalities. So we have providers who offer opioid prescriptions, which can lead to misuse or abuse. Some of those prescriptions can make their way in the street and then come back into misuse and abuse. Overdose death can result. And so there are a number of points at which you might tackle the problem. The first is just thinking about incentives and payment and reimbursements at the front end of the whole story. Another point that you could tackle is through the illicit sources of drugs, of which there are many. You can intervene at treatment level once somebody is addicted or people are addicted. We have to acknowledge that there are broader causes. In many parts of the country, we've had economic challenges, and where we were once prosperous, we're coming down. And in those places, we tend to see more addiction and drug-related and alcohol-related challenges. So that plays a role as well. There are also places that have prescription drug management plans. That's another intervention area. And then on the treatment side, there are naloxone access laws and Good Samaritan laws in which you can also intervene. So I think this map here provides at least a framework for thinking about places where people, and in extension in particular, might be able to make a contribution. The last slide that I'll show before I turn it over to Anne is just on the right-hand side are the drug overdose deaths per 100,000 people. And so you can see the hot spots around the country in the West and Southwest and in Appalachia and in some places in the East Coast. And if you look on the left map, you see the amount of opioids prescribed per person and how it varies. And there's quite a bit of overlap geographically in those two pictures. So that gives you some context of where this is happening and the connection of those fatalities to prescription opioids. And with that, I'm going to have pass it on to Annie, where she can kind of drill down and provide a little more context of the where and the who are affected most. And so I'll switch off. There you go, Annie.
All right. Thank you, Mark. I'm going to assume if you guys can't hear me, somebody will let me know. I'm coming to you from Nevada. I am at UNR, a professor at UNR, but I'm in the extension office, which is in the southern area. So I'm located in the heart of Las Vegas. So let's start with this slide. Really briefly, this is really kind of reiterating what Mark just showed us and kind of summarizing that a lot of the rates that are highest in the Appalachia area, the southern and western states, and the highest population of women, of people using it, are women actually in the South, ages 15 to 44. So let's go to the next slide. So this slide, so in general, this is the largest population that's affected by this. If you combine the 25 to 35 to 45, it's roughly 70% of all related deaths. And even though I'm showing you death rates, it's very similar to use rates. 70% of the death rates are in this age group from 25 to 44. And that's also the high, or 25 actually to 54. 25 to 44 is the highest emergency room visits or opioid related. And while it's less prevalent on the two extremes, if you look at the 0 to 24 and the 55 and plus, I want to look at those for just a second outside of this age group. So if we look at teens, starting with the youth, across the United States, about 10% of the population, this is the highest overdose death rates, is in teens, which, you know, 10% seems kind of low, but it's a high rate of our teens that have the problem. But what I want you to look at, even though it'll seem like I'm giving you a lot of demographic information, don't be consumed with the numbers, but the point that the opioid use, unlike a lot of other drugs, varies by state in terms of demographics. Very, very extreme and very different, I think, than you might expect. I've worked in this kind of area, not with opioids directly, but substance abuse and health for over 20 years. And the opioid does actually look different than a lot of the other drugs. So just for example, if you look at, in this slide, Texas and in Indiana and Alaska, they're higher, especially Alaska. They're almost twice the rate of teens. So they have a huge problem with teens using opioids and teen deaths up there in Alaska. And by the way, there are states with insufficient data, so keep that in mind. If you were to actually go and look up this data, you would see that there's quite a few states that they don't have collected data on. So I didn't report those dates because some of their information might be skewed, but these had sufficient data, so I used these as the example. So what does this mean for those states, for instance, Texas, Indiana, and Alaska? Well, I think what this means is that you want to ask questions before implementing programming in your state for these populations. So for example, one of the great questions would be, why do they use? So this slide shows you that for adults, it's almost, more than 2/3 of them, or roughly 2/3 of them, actually use for physical pain, for relief of physical pain. And then it just takes a big dive, and all the other ones are much closer. But getting high is about 12%, but 64% of them are using for relief of physical pain. Whereas if you go to teens in the next slide, it's not just physical pain. They're using it for anxiety, for relief, for relieving stress, also for euphoria, just to get high. And the studies show that teens feel like, why do they use opioids? They feel like, yeah, you can go ahead to the next slide. There we go. They feel like it's easy to get, and they consider it not to be an illegal drug. Why? Because it was prescribed legally and they're just using it. So that's a problem that they see it that way. So why they're using it could be very, very different. Go to the next slide. And I like this slide too, because it shows you what teens kind of think about it. and what's happening to the death rate. The majority of drug overdose deaths in 2015 for both males and females, the blue category, were unintentional. So, but also in that unintentional category, males are higher than females. And I think the green tells you why, is that females are higher than males in the fact that they're using it for suicide. So there you see a slight gender difference even within the age variation. So 86% of males are using it unintentionally, whereas 1/5, 22% of overdose deaths for females, for girls, adolescents, are suicide, whereas only about 9% for males. So that's a pretty big variation right there in terms of why they use. So let's go ahead and jump to the other end of the spectrum. The other end of the age cycle. Approximately 19% of overdose deaths are in the senior category, excuse me, older adults. But if you look at California and Nevada, where we live, it's as high as 33% of the death rates in our states over here on the West Coast are attributed to older adults. So that tells us, that that's more of an issue here in Nevada, and we have to address older adults more so than just teens. So one of the big issues that I see, and I must say that I have worked professionally in the area of gender responsive treatment and education and substance abuse for more than 20 years. So this is an area that I'm extremely passionate about, is looking at gender differences. The opioid use in males is roughly 65% and only 35% for females. That said, if you notice, I pointed out in this slide, I kind of showed some of the ones that are higher, even higher males. And they all seem to be that East Coast area, Connecticut, DC, Maryland, Massachusetts, New Hampshire, New Jersey, New York. They're as high as 73%. So there seems to be something going on up there, that it seems to be a larger problem for males. Whereas if you go to the next slide and look at females, these are the states that really see females as an issue. Idaho, Kansas, here in Nevada we have an issue, Oklahoma, Wyoming Wyoming actually, if you notice, that is actually more of a problem for women than it is for men in its use and in deaths. So they've actually exceeded the male rate, which is really unusual when the whole United States is 65 and 35. So I want to take just a minute because, I'm passionate about this, and I think it's extremely important when looking at substance abuse overall, but especially also in opioid use, is why there might be a gender difference. So if you go to the next slide, again, looking at the rate of deaths, it's increased horrifically over the last, I think most of the data since in the last 10, probably 5 to 10 years. The rate of deaths from opioid use, prescription use, has increased nearly 500% compared to just a little over 200% in men. Heroin deaths in women is twice the rate of men, has increased at twice the rate of men. Synthetic opioid related deaths have increased 850% in women. I mean, that's just unbelievable. That's outdoes most drugs that I've seen at all. Looking at adolescents in 2015, nearly 4% of adolescents that misuse pain relievers, more than half of those were girls. So it's increasing in girls as much as in women. And then finally, over the last 10 years, hospitalizations involving opioid pain relievers and heroin increased 75% for women, whereas only 55% for men. So you can see that the problem is increasing by leaps and bounds for women and girls in this country, something else that we need to look at. Gender differences in the impacts of specifically prescription, opioid use, and heroin use. The impacts are different in what happens when they take the drug. So women are more likely to experience chronic pain and use prescription pain medications for longer periods and high doses. If you look at the next bullet point, it goes on to say that women use smaller amounts for a shorter period of time before becoming dependent. So they call that telescoping, where they progress more quickly. They don't need very much of the drug and don't need to use it very long before they become dependent on it. So that's kind of an issue, which may explain why the deaths are rising in women. If more of them are using, it's progressing very fast. And then one more about gender. There's a lot of research that's come out, go ahead to the next slide, of UCLA's Integrated Substance Abuse Center. Dr. Breck has done a considerable amount of work on women and substance abuse. And there's quite a few researchers that have also looked at this, that women, one of the other reasons that women have these issues is related to psychological and emotional stress. A lot of it is biological, related to their body composition, their metabolic rate, or maybe fluctuations in their hormone levels. Social pathways, their partners are very dominating, or you could say that the women are very codependent, and so the partner introduces it to them and they just go right along with that. And then probably one of the big ones that we're well aware of, past experiences of physical and sexual abuse allow women to begin to utilize drugs for that reason. So there are definitely some gender differences that I think are extremely important to look at across the board. And one more demographic that I want to mention is race. This is also quite notable in opioid use. This is one of the few drugs, although stimulants is very closely tied to use a lot in white women, but opioid is 82% across the United States of deaths are to white non-Hispanic women, whereas you can see only 8% fall in the Black and the Hispanic population. The death rates among white non-Hispanic women is increasing the fastest of any of the races. And some researchers believe that it coincides with the shift toward prescribing opioids for chronic pain rather than just prescribing for acute or cancer, and many of them tending to be in the middle class, in the suburbs of our cities. So one more on race. I also wanted to show you that there are some states across the country that have a little bit variation in race. Maryland, for example, is probably the highest, where you see 27% of deaths for opioid use are found in the Black community. So that's probably the highest in that area. In terms of Hispanic, which one might expect, in Arizona, California, Colorado, and Texas, where there is a large Hispanic community, that number jumps from 8% to 17, 18, 19, even 22%. So there again, what does all this mean? I think what it means is that we have to look at the demographics within our state to see what is unique in our state, and then how do we address the problem. So I'm going to kind of wrap this up in the next 5 minutes or so. I want to kind of shift directions now that we understand a little bit about the demography. In terms of looking at how we might program, particularly in extension, what we might do, I think the first thing we have to look at is how prescription opioids are misused. And, this might be, news to some of you, and it might be old information to many of you, but the 4 major ways that opioids are misused is taking someone else's prescription, even if it's for legitimate medical purposes. So if my mom takes pain for back pain, and I also have back pain, I might view in my mind that that's legitimate, but it was prescribed to her, so it doesn't matter if it's the same reason. I'm taking her medication, and so it's misuse for me. Second way is taking it other than prescribed, which would be if my mom is taking medication for back pain and she decides she needs more, or she needs to take it more often, or she wants to snort or inject it. Boy, I'm really picking on my mom. She'd have a heart attack if she heard me say this, but hopefully she'll never hear this webinar. She doesn't use drugs, but I figured I would pick on my own family here. So the third one would be mixing opioids. So if she took the drug and she mixed it with alcohol because it gave her a better feel for, it took care of the pain even more and it helped her to check out even more. Or mixed it with a different drug that this pharmacist said, don't mix this drug with this drug because it can be very dangerous. Oh, okay, well, I think I will because it will weigh the pain even more. And then the last one is the one probably most people are familiar with, is people just getting the drug and using it to get high for that euphoric effect or to make them feel good. So what I wanted to point out on that, if you go to the next slide, prescription medication, which I think that Mark somewhat addressed already, is the most prescribed drug worldwide. For older adults, so if in your state it seems to be more of a problem with older adults, then you might want to look at prescription, at changing the way prescription is happening in your state. So for example, Medicare patients, almost 1/3 of all Medicare patients were prescribed opioid painkillers by their physician in 2015. 1/3 of all Medicare. That's horrendous. And then if you look at the next one, that same year, nearly 23% of Americans over the age of 50 abused painkiller. So what is the problem for seniors? That's the problem. They're being overprescribed. They're becoming addicted to it. And they take, it says they took them for reasons or in amounts beyond what their doctors prescribed. So for them, it's just my doctor fuels my drug for me, and that works for me, and it helps me get through, my life. Whereas if you look at adolescents, 18%, only, less than 1 in 5 adolescents obtain their drug from a medical professional. Where do they get them from? More than half of the adolescents get them for free from their friends or relatives. 17% bought or probably stole them from friends or relatives, went through their medicine cabinets. But the largest amount is more than half of them are just getting handouts from from their friends and relatives. So we would have to address that completely different than we might address in the case of older adults. So my little kind of summary slide is, what does all this data tell us? It tells us that there's no one size programming that fits everybody. Whatever the approach, though, that you would use in your state, in your community, should be specific, whether it's for teens, adults, older adults, women. There are different risks, there are different causes, there are different impacts for all of these different populations. In particular, access to gender responsive education. When you're talking about women, it has to be gender responsive. Behavioral interventions, treatment and support efforts designed specifically for the needs of women. If you're talking about adolescents, likely we need prevention programs. We need those clearinghouse of educating adults who are giving them these drugs and passing them along or not protecting them in their cabinets, etc. So, which is not really the problem as much for adults and seniors. So what do we do? Well, most of what's out there summarizes what we can do into 3 points. One is improve medication prescribing, whether it's from people taking control of their own health and telling them. I work with addicts every day, and they have to tell their doctor when he prescribes them, you need to take this. They say, I can't take this. I'm an addict and I'm not supposed to be taking this. And they say, well, just take it for a couple of days. They're very knowledgeable sometimes about the impact of that drug on that individual. So sometimes it means having the individual take control, and sometimes it might mean more educating doctors and the clinical environment. The second one is to prevent the abuse. And then the third one, to provide treatment and prevent death. And finally, there is no one size that fits all, but I kind of summarized extension approaches into these three categories. Prevention programs, which could apply, these could include direct education. So it might be doing direct education for, juveniles, or direct education for patients, or direct education for clinical, or direct education for treatment providers. So that's whether it's prevention or treatment, direct education can fall under that. But prevention programs would be part of it. The second thing would be to influence policy and initiatives within our states. And then finally, augment existing treatment programs, which again would be more the clinical side of it, but also could include direct education. And I'll just mention briefly that I've worked in this area for a very long time. I'm not clinical. I've partnered with our local university clinical psychology department to develop a program that can be used in clinical treatment settings, but it's educational for women. It started out primarily for stimulant use, because that's the primary substance of abuse and admissions in Nevada. So we developed a program to reduce the amount of stimulant use and education, extension education. I'm not going to talk about this program in the list, but it's called Healthy Steps to Freedom. And because it was geared towards stimulant, I'm not going to expand on it, but we have added opioid because it's on the rise in our population. And we've now included that in our direct education, but it's designed to augment existing treatment. So just a kind of a little bit of an example of how extension education can be used in treatment environments. So with that, I'm going to, who am I passing it on to? Are we back to Chris?
Back to me.
Oh, back to Mark. Okay.
Yeah, so I'll just take a few minutes to provide some examples of extension programming right now that are directed at opioids. And I want to say two things before I do that. The first is, it's for sure that there are other programs. These are just some samples, so I want to acknowledge that. And second, I probably won't be able to do each of these, describe each of these with much detail, or I'm just not going to be able to have time to talk about each one in great detail. So I'm just going to provide an overview. All right, so the first one is at Ohio State University. It's a collaboration between Ohio State University College of Pharmacy, Kroger, and Cardinal Health Foundation. And this is really along the lines of prevention and education, educating people of all ages about potential dangers of misusing prescription medications. There's a reference to your right there to Dreamland, which is an excellent book about the opioid epidemic in the United States. That's a primary reading if you really want to learn a lot of layers about what has happened and how we got to where we are. And so this second slide is just a summary of some of the things that are going on with Generation Rx. The Prosper study is kind of a combination of both outreach and research, where they're doing some randomized control trials looking at the effectiveness of this type of intervention or prevention activity. And it has been shown to reduce or prevent opioid misuse. And so that's another program that's happening right now at Penn State University. HERO, or Health Extension Rural Office Program, was created in New Mexico. This is being conducted by Utah State University. And again, it's more of along the lines of prevention and education. And one of the patterns that you'll see in a lot of these activities is that extension is partnering with others to engage in prevention or education programming, and that's the case here. This one is a more targeted kind of activity at Alabama A&M and Auburn University's extension. And here they're collaborating with police departments and counties to put drug drop boxes or drug take-back receptacles in various places. And this is another effective strategy for eliminating the excess opioids that might be used inappropriately. There are a number of opioid programs in the southern region, in Arkansas, Kentucky, and Virginia. And again, there are partnerships and along the lines of prevention and education. The Robert Wood Johnson's Culture of Health is a partnership with 4-H. And again, they're looking at working with communities and looking at the overall issue and trying to determine the best course of action for communities to address their challenges. And that's actually very similar to the CAPE program. This was a SAMHSA USDA collaboration that was led by the North Central Regional Center for Rural Development, along with the other rural development centers. And so CAPE stands for Community Assessment, Education, Promote Behavioral Health Planning and Evaluation. There's a link there to resources. The one that's, two things that are most relevant here is that we've developed and tested a curriculum that combines mental health literacy with community capacity building tools. The curriculum is for extension-oriented people who are working in communities and want to help build capacity to address things like the opioid crisis. We also conducted a nationally representative survey of mental health literacy, including an assessment of prescription drug misuse. And on that website, healthbench.info, you can gain access to some information or results from those studies. And here, we just tried to evaluate the degree to which people understood what it meant to misuse prescription drugs. And you can see here that nearly a third of the people were not able to identify prescription drug misuse when given a description of it. Men are much less able to identify prescription drug misuse than women. Younger people are not very good at identifying prescription drug misuse. So this kind of resource might help in terms of thinking about targeting education and prevention programming. That's available on the website. This is a transition slide to Alicia Shipley, who will talk about rural and health safety education grants this year. This one is led by Purdue University, and one of the components is an opioid webinar series. And the very first webinar will be next week on December 5th at 2 p.m. Eastern Time. The title of that is How the Opioid Crisis Impacts Individuals in Rural Communities. You can go to the link cited there below for more information, and everyone is welcome to join. We'll be doing a series of 8 webinars over the next year and a half or two, looking at different aspects of health literacy and opioid misuse and best practices to prevent opioid misuse. And with that, I will transition and hand it over to Alicia.
On behalf of NIFA, and share with everyone, what projects we have funded at the agency that directly address the opioid issue in rural communities. So Mark had mentioned that Purdue was one of the universities that was funded, and the webinar series was a part of one of their awards, and I'll talk about those awards in just a moment. But I wanted to briefly share with you about the Rural Health and Safety Education Grant Program. It's really about putting good health information into the hands of rural citizens across the United States. And it is through an extension-based delivery model and through the development or implementation of evidence-based programs and approaches. And so in the past, we have tended to focus on individual and family health education. We have for the past 10 years. And out of these projects, they're required to use research-informed evidence-based programming. This year, they fell on the continuum of evidence-based. And then also, they are required to implement their projects in federally classified rural areas. And then they're required to coordinate with state offices of rural health. And all of those requirements really get us the best projects that we can. And so what was new in FY17 is that we received double the funding that we usually have to focus specifically on combating opioid abuse in rural areas. So priority this year was given 2 proposals that focused on opioid abuse in rural communities. And you can, there's a link right there to all of the projects that were funded. We did fund 9 projects, and 6 of those specifically focused on opioid abuse. So we received $3 million this year from Congress in the appropriations bill. Mark, could you go to the next slide, please? Thank you. So as I said, we funded 6 projects. I'm very excited about these projects. They actually really touch on a lot of what Annie was saying in terms of what we need to do moving forward with respect to prevention. And 4 of these projects actually use either a model or a recommended program from the Surgeon General's report last year that came out on facing addiction. So we're going to start with Purdue. And so Purdue is really implementing a multi-state project, and they are implementing Strengthening Families, which is one of those programs that was in the Surgeon General's report. And Strengthening Families was developed at Iowa State, and it really focuses on it's a parent-child curriculum, and it really focuses on building parenting skills, strong family relationships, and also reducing risk behavior among youth. And so, in addition to that, as Mark mentioned, another component of their project was a regional webinar series that's focusing on different aspects of the opioid epidemic. And by the end of this project, they hope to deliver this program in 18 counties across Indiana, South Dakota, and Kansas, and with the hopes of serving 360 families. And so the next project is in University of Arkansas, and it really focuses on addressing the misuse and abuse by offering different options for pain management besides medication. And so that team is going to partner with healthcare providers and pharmacists to really implement, things like exercise and yoga and stress management as an alternative to actually getting prescribed opioids. And they're going to focus on adult Arkansans with a primary or secondary pain diagnosis. And so next with Iowa State, they are also they're implementing the crosser model that Mark had mentioned. And so they are also implementing Strengthening Families 10 to 14 in 3 rural communities in Iowa. And they're going to also include opioid-specific educational content within their programming. Next with Mississippi State University, Mississippi is really trying to look to see what should be done. And they're going to have a series of focus groups and bringing stakeholders together to figure out what can be done in Mississippi to address the issue, and also developing educational resources and having a take box campaign and social media strategies to really address the issue. And in North Carolina, they are also implementing Strengthening Families in 2 rural communities in there, and they're actually adding on substance abuse educational materials with their project as well. And with Virginia Tech, their project is twofold. They are actually also implementing the Prosper model and also implementing Strengthening Families 10 to 14, as well as a life skills training program. And then they also are implementing a hospital patient education program that they developed there at Virginia Tech to really educate hospital patients about the dangers associated with opioid pain medications, and to provide them with access to support they need or their family members need with the pain prescriptions. So these are these projects are all 2-year projects, and so they are on the ground running, and I look forward to seeing the outcomes of those. And of course, NIFA is a partner with ECOP in addressing this issue. So thank you, Mark.
Thanks, Alicia. Thanks, Mark and Annie. Great information, a lot of great projects that are happening across the country right now. But what we don't know is everything that's happening across the country right now within your land-grant universities, within your extension systems. And so what we would like to do as the ECOP program committee is to collect more information about these projects so that we can share it. If you don't have capacity within your state, within your institution to do the programming, wouldn't it be nice to go to the website and find other resources that in extension we might talk about as stealing or sharing, whichever way you might want to look at it. And so we'd like to fill up an opioid toolbox. And so I've got a website. We've got a Qualtrics site set up that we hope people will be able to just jump in real quick. It's a very short survey to collect this information that you see on the slide. Please copy the URL and save it, and then share it with others, with your specialists or program leaders, so that you could submit other curricula, programs, resources that would be useful to others within our family, and then we can, be able to sort that and summarize it and get it back out to you and share it so you can look at it and use it as well. So Mark, if you could just jump on to the next slide. I think what we've got some time here, and this is the most important part potentially of this seminar or webinar, is to talk about next steps. Where can we go? Where should we go? I think what Annie and Mark presented, there's a pretty compelling case for us to address the opioid crisis. There's a lot of great examples of programs that are happening within states, but do we do more as a system? So as extension directors and administrators, what are those opportunities? Do we need some national leadership in regard to the opioid epidemic crisis? Do we need a task force? Is it an individual? Is it an institution that takes the lead there? So we could talk about leadership. We could talk about perhaps training needs. Is there a need for some type of nationally coordinated training in regard to some of the prevention programs or some of the programs that could be used to influence policy? Do we have capacity within our systems, and could some of this training help to develop some of that capacity? What are some of the other basic resource needs that we could or should have? Are there other opportunities to partner with NIFA, with other agencies, with other nonprofits or health institutions? So there's a lot that could be out there. And I see a note here from Chuck. Do we know which types of intervention are most effective? And a number of different options that we could respond to there. So perhaps if you have comments, unmute yourself and let's have a discussion. We've got at least 10 minutes here. We could certainly take some more time, but I think the core question is, what are those next steps? What capacity might you need that we could address collectively? What are your thoughts? And I could start picking on people if I don't hear people make comments. So I'm going to pick on Roger Renkamp. I know Roger will have some good thoughts for the nation.
Yeah, I just got away from typing here, but yeah, thanks. Absolutely. I think I think the questions about, research-based or evidence-based and that kind of thing, and I know there's different definitions of those, but I think we do need to really look at, in a lot of cases, as much as possible, replicating evidence-based programs, that are as we're trying to do here in Ohio, is use those that are kind of number one, evidence-based, but also shovel-ready as we move ahead. So I think that's a key question, I think, that was asked, I think, in the chat about evidence-based programs. Our Generation Rx program, particularly from Ohio, has been around for about 10 years, and I'm not trying to sell this program, but it has a 10-year track record and has been thoroughly evaluated over those years, and it's already used nationally. I think it's used in all 50 states already. So if you are interested in that particular program, just go to generationrx.org, and it'll take you to our College of Pharmacy site, and where you can find out a little bit more about some of the materials that are in fact ready. The other piece I forgot to mention, I think, as I was sending in slides for it, is there are some opportunities through our 4-H program. One of the things that we have in Ohio here is a traveling medicine chest that travels around to county fairs and things like that, where we're really talking about specifically about misuse of prescription drugs. So that's another innovation, I think, that has some potential, is our youth programs, in fact, as a vehicle for doing some of this. Annie, I really appreciate your comments and your overall assessment of the situation. And I'll probably add here, I guess, as I look at some of the Appalachian region, which a lot of people know Ohio, of course, to be, think about Cincinnati, Cleveland, and Columbus. And yes, we are rather urban in many ways, but a lot of Ohio also is part of Appalachia, along with West Virginia, Kentucky, and North Carolina and Tennessee. And one of the things that I think we refer to the opiate challenge here as being a disease of despair, and I think both Mark and Annie talked a little bit about that. But in Appalachia, and particularly, we're looking at the target population as being 50 plus white males, and we call it a disease of despair because it usually begins with injury, job loss, sometimes in Appalachia, and loss of self-worth, and all those things create kind of the perfect storm for abuse and addiction. Here in Ohio, we lead the nation, I think, in opiate deaths, with someone dying about once every 90 minutes here in the state of Ohio. So it has been a high priority for us to address. And the two things that we are doing, of course, are Generation Rx. And the other piece that is a big part of Mark's program also is mental health first aid, because we see a lot of covariance, I think, with mental health issues. So that's another one. And Mark, I don't know if you want to mention a little bit more about mental health first aid as being one of the things that you're supporting, I think, through the CAPE project. How's that for passing the buck along there?
Yeah, just real quickly, I don't want to monopolize the time, but the CAPE project does have a component, as I mentioned, with the curriculum that combines the mental health first aid training. If you're going to work in a community, it may be that your leaders don't have a sense of some of the behavioral health issues and factors and drivers, including things like the opioid. And so what mental health first aid does is give that non-specialist enough background to have a conversation and be able to start working with professionals and working together as a community to come up with strategies that are specific to your community. And every place is different, as Annie listed. The way these challenges pop up are quite different in the needs in the community. There may be programs already for some population subgroups, but not for others. And so maybe that's another way to think about it, is what can Extension do to fill those gaps, and what are those gaps?
Mark, this is Teresa Hogan. I'm sitting in for Christine Geith with E-Extension, and I'll just, this is great information, and I would just offer that many of you, or some of you, may know that there are 3 issue areas, of which behavioral health, with an emphasis on opioid overuse, is one of the priorities with E-Extension. And the Impact Collaborative is a quickly emerging arena where no matter if it's a local community or it's a multiple collection of states can come together in a lab and innovate and create programs to address some of these issues. Chris asked me to pay particular attention on this call as to what opportunities are there for partnerships, and from the great presentation that you all just made, I would really leave the invitation and feel quite confident Chris would be supportive of let's explore partnerships that we can really optimize and use the Impact Collaborative to its fullest extent, not only again for the local communities, but for advancing those programs that may be thought of or are on the ground at this point.
Hi, Chuck. This is Rick Klemme from University of New Hampshire. Can you hear me?
Yes.
Again.
Yes.
Yeah, just to chime in. One, thanks so much for doing this webinar. Totally very timely and incredibly informative. I'm involved with a couple of things at UNH, and I wanted to sort of throw out maybe a question for some follow-up. I am an instructor for youth mental health first aid and been doing that with 2 other extension folks and many other folks through the Project Aware initiative with our Department of Education. There's also a new initiative, very timely at UNH on behavioral health, just trying to see what everyone's doing and how we might partner and have greater impact. Also, just in my role as I work in the youth and family arena, which means with 4-H and more broadly with at-risk young people, families, and communities. And so I've been very involved with just the substance abuse prevention and clearly the opioid crisis with a number of drug-free community coalitions doing everything from prevention to intervention to actual treatment programs like intensive outpatient and various levels of counseling for kids and families. I just think it would be a great resource. There was so much that was shared today, and just little tidbits here in the comments, just about who's doing what, like just learning about some of the initiatives like the Robert Wood Johnson effort with the 4-H Council, and just some different things that are even being done at the state level, or my particular interest is more locally. What kind of efforts, and especially if anything very specific to the opioid crisis or substance abuse, a little bit more generally, that's going on in local counties, whether they're evidence-based programs or just, good informed practices. It'd be great if we could just kind of, keep or start generating maybe a little bit of a repository of who's doing what. I'm currently listed also on the e-extension and contributed a little bit to some of the resources on that website for extension professionals, but I know there's so many more people doing so much more. Just wonder if there's some way for us to sort of stay in touch and keep informed as to what we're doing or maybe doing down the road. Thanks a lot.
Rick, thanks for the question. And I guess, can I ask a question in return? So on this Qualtrics survey, I know this, if people respond, and please, I hope people will respond, this would be an opportunity for people to log in what they're doing right now. The only problem with that is it could become dated in 3 weeks because somebody else might be picking something up new at that time. So we might need to pay some attention to how do we keep it fresh. But first of all, it'd be great if everyone truly took 3 minutes, 5 minutes to log in that base information. Like we're doing this with Robert Wood Johnson in our state, or whatever the project is. It won't take much. So please respond.
This is Sandy Bailey with Montana State University Extension, and we're a recipient of one of the Rural Health and Safety Education grants. And while not directly related from last year, and while not directly related to opioid, while we see more opioids used in Montana, we're still in the methamphetamine phase here. But rather than focus on substance abuse per se, we've been focusing on mental health. So like Mark, we're using the mental health first aid the adult version to help with, to create mental health literacy as well as community capacity building, and also so people know what to do when there's an emergency in rural areas. But then we've got a larger program that is relatively new to the US called Youth Aware of Mental Health. And the focus obviously also includes issues related to substance abuse. We don't have the data back now, but the data from the European study really found that youth had fewer suicide attempts and less suicidality, suicide thoughts. And here the initial pilot is finding that youth are reaching out more to adults when they are having problems. So I'll keep you up to date, but that's been an exciting new program that's only been offered with one group in Texas and then those of us in Montana.
That is great.
Hi, this is Jorge Atiles from Oklahoma State University. And this is more of a comment rather than a question, but to Chuck and the leadership at ECOP, it appears to me that given the statistics that were shared, that perhaps there should be some national level strategic alliances pursued. Let's say with AARP, for example, to try to reach out that aging adult group that is using these prescription drugs, and others that might be also dealing with teens and especially females. So in terms of trying to influence that policy initiative goal that was expressed today, perhaps those strategic alliances should be made. One of the things that I was wondering, depending on what happens with healthcare nationally, because we talk about prescription drugs, they need to be prescribed. It will be easier for people to get them when they have health insurance and they are able to pay, for the medicine rather than when they don't have health insurance and maybe that medicine might be prohibitive. But if we're looking at a mostly a wide population and mostly females, I don't know what the statistics tell us in terms of their access to health care and access to, to healthcare that can pay for their medicine. I mean, I don't know if there's anything out there, Annie, that you may be able to share regarding those statistics, because I mean, we are facing with something with overprescription by doctors, by individuals that may not be able to utilize this prescription adequately, which also brings to our attention the work that we need to do as an extension service with caregivers. But this is a very complex issue that have many different legs that we need to attack. So I like your approach in terms of citing those three priorities beyond just simply education, but also influencing policy. So Annie, do you know anything about access to the prescription drugs because they have insurance or are wealthy or so forth?
Can you hear me? I think I was muted there.
Yes.
Okay. No, I don't actually. My work has really centered on women, and like I believe it was Sandy said, on the West Coast we have a huge methamphetamine problem, which is what I've been doing for 20 years. But I definitely think that it's something that we need to look at, and in terms of access as well. I don't know, maybe somebody else has thoughts on that. It's a good question, and it is extremely complex, which is probably one of the things that I wanted to demonstrate more than anything, because I think we try to simplify too quickly and say, oh, here's a problem, here's a solution. And I wish it was that simple. It's not. But I think there are lots of things that extension could play a role in. I think that's kind of the purpose of this meeting is what is that role? And how can we narrow down the scope, knowing that it's such a complex issue?
Yeah, I think perhaps, in working with those, I'm going to call them national institutes or academies, whether it's pharmaceuticals or American, medical association and so forth, there could be some potential here because we all may be trying to reinvent the wheel. And although we are trying to figure out what is being done through extension, there might be other programs out there that might even have some evidence of working, that if we come together and we can be as an extension arm to legitimate good organizations, we might be able to get more bang for our buck. And actually even together access better funding to be able to do a good job.
There's some big questions there without a doubt, and maybe some things that we need to look at to get some answers. According to the clock, I've got we're about 5 minutes after 3, or 4 o'clock if you're on the East Coast. I think we should probably start to look at a wrap up here. This has been recorded. It will be posted. The slides, we'll get them copied and posted as well, along with the links here. So I want to thank everyone for your participation. I need to turn this back over to Chuck Hibbard as the chair of ECOP for his concluding thoughts.
Well, thank you, Chris and team, very, very much. Extremely informative, lots of good insight. I was listening to Jorge as he was talking about how do we think about the ecosystem approach, all the moving parts, and it would be interesting to know to what extent other entities or groups are really getting active in this regard. The whole health insurance question, I think, is a really interesting question. So we'll follow up with some of those ideas. Very, very happy to do that. I think most importantly, though, is all of us have this leadership opportunity. And in Nebraska, we haven't really jumped on board yet, but it is now becoming an emerging issue in Nebraska as well. So we are now on board and ready to move forward. So we all have some really important decisions to make about how we respond, what is the best mode for us, who are the key partners. And I think this webinar, Chris and all, really has helped us think about this. So the first of 8 additional webinars over the course of the next 12 months to help extension directors and administrators think about their leadership role and opportunity on really critical issues for the U.S. and for our state. So thank you all for your interest in this issue, the good information that was shared, and we'll see you all again in January with our next installment of Next Generation Extension Learning for Leaders. Thank you all.